Good morning and welcome again to the Brompton Grand Rounds. It's an absolute pleasure this morning to invite along Jiang from Shanghai Chest Hospital to talk to us about lung cancer screening in China. He is Deputy Chair of the ISLC Screening Committee, an attending surgeon in China, and in one of the busiest institutions I have ever known worldwide. So it's an absolute honour to hear from you. Please do get started.
Okay, good morning, Professor Lim and Professor Ashley Fan, and dear all colleagues. It's really my honor to give my presentation here. Thank you all for joining this meeting. And my name is Long Jiang, from Shanghai Chest Hospital, China. Today, I will talk about refining strategies for screening high-risk population and its insights from regions with China's highest risk population with lung cancer morbidity and mortality rate. And while lung cancer is a worldwide health crisis, and certain areas show a shocking and unfair burden. As you can see on the map, we are focusing on Yunnan province, specifically Shanghai countries. And these areas have lung cancer rates that are among the highest in the world. What is especially striking and scientifically important is the high number among women who never smoked. This unique pattern presents a side but important nature test case, a model for study pollution-caused cancer. And the main cause found through decades of research is severe indoor air pollution, and coming from the long-term burning of smoking coal for heating and cooking, often in homes with little to no fresh air flow. And the cause of Shanghai lung cancer are many. Through one factor stand out, the main risk factor can be grouped as follows: indoor air pollution, genetic risk, smoking and secondhand smoke, work exposure, pollutions, and some other factors. Let's take a close look at the main cause. This image here shows the reality. For many households, smoking coal is the main fuel for daily life. And this practice creates extremely high indoor levels of particles and toxic gases. And a crucial finding from long-term study is that exposure during childhood before age 18 appears to give a great risk for developing lung cancer later in life than the same exposure during adulthood. In Shanghai, environmental pollution from coal burning is the main cause. What exactly makes this smoky coal so dangerous? It is rich in high cancer cause pH, and among the many compounds found, these four are of special concern due to their strong cancer-causing ability. The consistent high-level exposure to this mixture of pH from a young age is what drives the high rates of lung cancer in this population. Now let's turn to the host. Why do some people develop cancer while others with similar exposure do not? Genetic risk play a key role. Shanghai population has found several key genetic factors: cell repair genes, GSTM1 gene deletion, immune system genes, and family clustering. Given this unique profile, a one-size-fits-all screen approach is not enough. This leads to the development of a customer screen method, which builds upon the national guideline. The China National Lung Cancer Screening Guideline was a major step forward. It officially includes non-smoking risk factors, recommended personal screen intervals, and emphasized a approach for managing fundings. This provided the framework for our more specific protocols. And here in our Xuanwei screen protocol, we give customer approaches. For Xuanwei, we set up a highly specific protocols. Screen is recommended for people aged 30 to 80. Uh, that means a much wide range than typical guidelines, who have heavily co-exposure with or without a significant smoking history. It also includes patients with work exposure or a strong family history of lung cancer. These targeted approaches ensure that we can focus our resources on the people who are truly at the highest risk based on the unique environmental and genetic factors in this area. To implement this in a resources-limited rural area, we rely heavily on technology. This is how we bridge the gap between advanced test and the remote population. Mobile CT units brings the screen directly to the village, and removing transportation barriers from residents, and the AI assistant diagnostic system provides an initial reading, making suspicious nodules to improve efficiency. And the remote reporting by experts in major centers like Shanghai or Beijing overcomes the lack of local specialists and ensure high-quality interpretation of every scan. And the core technology enables this entire strategy is low-dose CT scan. And it is, as we all know, it is a golden standard for lung cancer screening for several reasons. It's better detection and its low radiation dose and its proven success in many countries. And beyond smoking, we also have other methods for risk assessment. For effective screening starts with accurately identify who to screen. While many international risk models, as well know, like the PLCO models, focus heavily on smoking history, and for this population, it's not enough. So our risk assessment model are tailored to the local context. We have moved beyond a main focus on smoking to heavyweight other critical factors, such as pH exposure, indoor air pollution levels, and the genetic markers and family histories. And these multi-sided approaches ensure we are screening the right people at the right time. And now let's look at AI. AI is not just a tool for efficiency. It is a changing force for accuracy in our screen program. And the AI assistant reading system provides several key advantages. And it can improve detection, it can reduce false positives, and it can help us with nodal classification, and it can also do some predictive analysis. Mm, so what has been the impact of this targeted technology-enabled screen program? The results are profound, representing a true big change in how lung cancer is diagnosed in this area. As 2023 data show, we have achieved a dramatic stage shift. The detection rate for stage 1 lung cancer increased from 48% to over 65%. This means we are finding the majority of cancers at their earliest and the most curable stage. And this is a direct result of proactive screening in high-risk population, fundamentally changing the clinical presentation of the disease from advanced to early stage. And if we look deeper, okay, if we look deeper into the data reviews and even more impressive change, we are not just finding more stage 1 lung cancer, we are finding more very early stage 1A1 cancers. And the detection rate from these very small local tumors rose from 16% to nearly 28%. And uh, they are the cancers that are most suitable for minimal invasive surgeries and have the highest probabilities of a complete cure. And ultimately, the goal of any screening program is to save lives. So our data show that this stage shift translates directly into remarkable survival benefits. And a critical consideration for any large-scale public health uh, initiatives is its cost effectiveness. The benefits of our program are clear. By funding more and more cancers at an early stage, low-dose CT scan screen dramatically improves survival. This, in turn, can reduce the need for more complex and costly late-stage treatments such as extensive chemotherapy, radiotherapy, target therapy, immunotherapy, which are a significant burden on the healthcare system. Okay. However, no programs is without its challenges. Our ongoing challenge and future direction is to continuously improve the screening protocols. This involves refining risk models to better selection participants and improve AI program to reduce false positives and determine the most effective and economic screen intervals for different risk levels. Okay, in summary, our work in Shanghai and other high risk regions have led to several conclusions. First, targeted LDCT screen is a powerful tool that can clearly reduce lung cancer death rate, even in resources limited areas. And second, empowering and training local healthcare workers, such as village doctors, is essentially for the last mile delivery of this advanced screening program. They are the bridge to the community. And third, there is a clean call to action for governments and public health bodies to expand and support screening in other high-risk regions defined by environmental or work exposures. And finally, for the research community, a key priority must be to standardize environmental markers panel to better identify and rank at-risk people worldwide. And now I would like to give a poll question for reflection. Which strategies do you think is most critical for sustaining screening in resources limited areas, as we consider how to apply this license elsewhere? I would like to pose a question for you to reflect on. Which of these strategies do you believe is most critical for the long-term sustainability of a screening program in resources limited area? A is mobile city units, B is village doctor training, and C is AI diagnosis, and D is behavior incentives. Each of these is a vital component for the system we have built. The hardware, the human uh, element and the advanced software and the community engagement all work in concert. And maybe I think, in my opinion, the trained village doctors is the most important for long-term trust and sustainability. Okay, that concludes my formal presentation. We have seen how a deeper understanding of local disease patterns and the risk factors can inform a highly effective technology-driven screening program that produce real impact on early diagnosis and survival. And thank you all for your attention. And I would now be happy to open the floor for questions and discussions. Thank you.
Thank you so much, Professor Jiang. We have a Q&A. Please, everyone, if you do have questions, post them in the
Okay.
Q&A and I can read those out online for you. We do have one question to start with. I'm afraid I can't let people speak. So if you instead of raising your hand, if you can actually put your questions in the chat that in the Q&A, that would be better. In terms of the first question we've got is here about screening for non-smoker lung cancers. Can you explain the value of selective genetic testing? For example, could a single nucleotide polymorphism confer added risk of pulmonary cancer in never smokers? And can you talk a little bit about the interplay between germline variants in DNA repair genes and passive exposure to cigarette smoke in the pathogenesis of non-smoker lung cancer? Complex question.
Yes, I think maybe for research, I think it's important to do some uh, uh, I mean do some gene or DNA test for research purpose. But for our screen program now, we didn't include a DNA screen, and we only give patients with such as environmental risk factor or some work exposure to work exposure. But for research purpose, I think we can include, but till now we do not include so many DNA tests in choosing candidate for lung cancer screen. We do not include this. But I think in the future, if we have already organized a panel, a DNA panel, we can give this before CT scan, but till now we do not.
Thank you very much. No, just on the same theme, we've got a question about
Yeah.
using AI on an epidemiological basis for screening of non-smoker lung cancers. Do you think that that's something on a more broad scale that will come into play?
Oh yes. Because in China, I think it's we do face some different problems in other countries. Because in China, in some rural areas, the doctors in rural areas, they do not familiar with how to judge judge pulmonary nodules, how to judge it's safe or it's dangerous. It's very difficult for them to read the CT scan. So if we only give them CT scan, but the doctors in rural areas, they cannot give a diagnose to people. And in this circumstance, I think AI is very important. And AI can, after CT scan, AI can do a second scan, and AI can give some to narrow down which population have risk CT scan result, and expert in some major centers, and they can review the AI diagnose. And in these rural areas, we do lung cancer screening. Uh, first is CT scan, and the second is AI AI scan, and the third is expert to review and give a final diagnosis. Yeah.
Do you integrate? So we have a similar system. We have a commercial piece of software which helps us use AI guided nodule detection
Yeah.
here in the UK. Um, do you
Okay.
combine AI-based nodule detection with existing screening calculators, existing models of um, prediction for high-risk nodules and then ongoing imaging as you would have done in the pre-screening era? How do you integrate that with existing models, and what other existing models do you use?
Okay, yes. I think the existing models will also have in major centers in some big hospitals. Almost every hospitals we do have our own AI systems to help our daily work. But in these rural areas, I think because we do CT scan for mobile CT scan, we do lung cancer screen, and the DICOM image is different. I think it's very it's different to combine the mobile CT scan result to our existent uh, AI system in our hospital. So we have to train and develop a new AI system for lung cancer screening in rural areas. I think it's a little bit different, but it's easy if we have experience in this AI system in so many hospitals. It's easy to develop a new one. Yeah, but a little different with already used.
I've got the next question for you. So, once you've detected all
Okay.
these extra nodules, and you talked about ultra early detection, these are very small, sub-centimeter, typically ground glass, I
Yeah.
expect. What do you do with them all? It's in a 30-year-old, I presume you have a reasonable discussion about resection and sublobal resections. But in the elderly patients, what do you do with them? Do you continue to screen them? Do you resect them? Because we have a very highly morbid elderly population as we get into the 80s here. Some of those patients are not particularly fit. So is this cost effective? I think is probably what I'm asking you. And do you treat everybody?
Yes, it really, I think it's really that makes sense about for older patients. In our program, we include patients as age 18, but in our daily life, I think China we nowadays we have more and more old people. So in our daily life, in our daily work, we have patients, more and more old patients, even 90 or even older than 90. And I think their physical status is very good. They can tolerate to even a lobectomy. They can, but for lung cancer screen, as you say, we must consider cost effectiveness. I think maybe if we are trying to make a lung cancer screen program plan, we have to consider the natural age of in this area. If in Yunnan province, I think more and more people they can uh, we have more and more old people, so we can include patients as age 18. But in Shanghai, maybe we also do resection for patients uh, older than age 18, and their physical status is very good. And yes, I think maybe I don't think age is the only factors to choose uh, treatment methods. Maybe we consider more for patients' physical status.
Yeah, absolutely, absolutely.
Yeah.
And there's lots of questions about what you do epidemiologically. One question from one of your Asian colleagues: Do you with the regarding domestic cooking and coal smoke exposure, is this now changing in rural areas of China or large numbers still exposed to this? And once screening has detected a lung cancer patient, do you do anything to reduce their further risk of coal smoke, like we do with cigarette smokes? Do you have a kind of national program for reducing that?
Yes, it's very important in this area because many years ago they do have indoor air pollution, and we already uh, know that indoor air pollution is a risk factor for lung cancer. So this situation is already changed, totally changed in this area. Uh, the indoor air pollution is not the main cause in this area, but it's quite strange. Uh, After we remove the indoor air pollution in this area, the incidence of lung cancer in this area is still very high nowadays, still very high. It didn't reduce after we remove indoor air pollution. And maybe we guess it's something about gene, uh, their gene allergen or other uh,
Predisposition.
yes, till now we do not have we don't know what is the real cause for so high incidence of lung cancer in this area. We do not know now. I'm not sure if uh, I think I would like to say how about the cost for lung cancer for a CT scan in UK, but in China, the cost of a CT scan is very cheap, very cheap. It's only about uh, I would like to say $30 for
Wow.
a CT scan. So in China, more and more people choose to have a CT scan by themselves, even it doesn't covered by health insurance. So we have more and more uh, small pulmonary nodules detected instantial. So in our daily work, uh, we have to meet more and more people after CT scan. They have found small pulmonary nodules, and they are trying to get doctors' help if uh, they need to have the very small nodules to be resected. So it's another problem in China. So I think in China, different cities or different areas meet with different problems. In rural areas, uh, uh, have them to have their lung cancer to be detected. And in some major cities, I think maybe I would like to say sometimes it's overdiagnosis because CT scan is very cheap. So different cities have different problem. I would like to see. Yeah.
You see a very wide spectrum of socioeconomic divide from the very one end to the very other end. I expect you
Yeah.
deal with extremes of diversity as well. One final question then, as we're approaching the end. We do have a question about setting up a screening program in areas where CT isn't readily available. Do you think it is possible to take it back to the bare bones and be able to do this with two-dimensional imaging? What are your thoughts, or maybe using alternative methods for screening? What are your thoughts on that? Not easy.
Okay. Yeah. Mm, I think uh, I think I would like to say maybe I think it's easy to overcome these barriers because we have mobile CT scan and we can have the mobile CT to every village to some remote area. We can uh, give people live in long distance to have CT scan. I think maybe it's easy, but another problem is after CT scan, we do not have enough doctors to review the CT scan, to review the image. So I think in this circumstance, I think in this situation, AI would be very helpful. After CT scan, who to review the image? I think maybe AI to review it first. Then the expert in major centers can review the second times and make the final diagnosis.
Absolutely. Reducing the bottleneck of imaging interpretation. Certainly a problem
Mm.
here. Well, we've reached the end of our time, so thank you so much for joining us this morning, and thank you for overcoming the technical difficulties of internet connections as well this morning. Um, I am very grateful for your presentation. Thank you to everyone for joining us for this meeting this morning, and wish you all a very happy and pleasant day. Thank
Thank
you.
you.
Bye bye.
Bye bye.